Good afternoon. Thanks for joining us for Medical Grand Rounds. I'm David Schwartz, Chair of Medicine. This presentation is going to be recorded for future reference. You'll be muted when you enter the meeting, and at the bottom of your screen is a Q&A icon. Use this icon to submit questions, and submit as many questions as you like. The more questions, the better the discussion at the end of the talk. Do not use the chat feature, just use the Q&A icon. I'll moderate the question answer period at the end of the presentation. SARS-CoV-2 infection has been reported to infect almost every organ in our body. While the primary impact of the organism is the lung, we've learned that SARS-CoV-2 can infect the heart, the kidneys, the GI tract, the vasculature, and the brain. In relation to neurologic manifestations, we've seen presentations of anosmia to small and large vessel stroke to encephalopathy. Characteristics of the organism and the host are key to determining the many neurologic manifestations of this infection. Today, we have three outstanding speakers with expertise in this area. The lineup includes Dr. David Beckham, who will discuss the neuroinvasive infections in general and the neurotropic effects of SARS-CoV-2. Dr. Ken Adler will discuss the many clinical manifestations associated with SARS-CoV-2, specifically the neurologic manifestations. And Dr. Sarah Jolley will discuss the long-term cognitive dysfunction that occurs as a result of extended ICU care and specifically infection with SARS-CoV-2. Okay, let's go ahead and get started. Dr. Beckham is first in terms of the presentations.
All right, thank you, David. Appreciate it. All right, so I'm just going to launch right into this. Let me see if I can get my next slide to come up here. There we go. So as was mentioned, we're just going to go over some of the neurologic and cognitive sequelae of SARS. And so first, I'm going to just quickly touch on some of the acute and direct effects of different viruses in the central nervous system. So I want to I'll focus a little bit on encephalitis, talk a little bit about CNS vasculitis with a focus on varicella zoster virus. And then I'll talk in a minute just a little bit about some of the indirect effects, and then we'll talk specifically about SARS-CoV-2 for a couple of minutes, and then we'll lead into the next talks. So in general, one of the important features that we've been looking at as we've seen these patients is to try to understand if patients presenting with a SARS-CoV-2 infection and potential neurologic involvement have features that are consistent with viruses that we've taken care of in the past. So one of the important features of a viral encephalitis is mainly, I want to point out this encephalitis part, is that there's inflammation in the spinal fluid. So here you can see an example of HSV encephalitis. You can see on the MRI this bright white or hyperintense signal in the medial temporal lobes. These patients present with lymphocytic pleocytosis in the spinal fluid. They have a very characteristic cortical gray matter disease in these cortical regions. And then the way you make the diagnosis is with PCR. And again, this virus mainly infects neurons. So this is a very characteristic pattern for this specific virus. West Nile is a little different. It tends to cause more of a subcortical encephalitis, so infect these deep gray regions in the brain. Again, causes a CSF pleocytosis, so the itis is very important. And again, affects these subcortical gray matter regions. We make the diagnosis mainly with antibody. Interestingly, a lot of these RNA viruses, whether it's West Nile virus or enterovirus D68, it's actually kind of difficult sometimes to pick up the actual nucleic acid in the spinal fluid on some of these patients. And again, this mainly infects neurons and typically has a very characteristic pattern. Another important pathogen, progressive multifocal leukoencephalopathy, caused by JC virus, again, has a very characteristic pattern, causes subcortical white matter lesions. Again, patients usually present with a pleocytosis, very characteristic white matter lesions. Again, make the diagnosis with a JC virus PCR. And the pattern, again, similar to the previous two, reflects the pathogenesis of the virus itself. So the virus infects mainly oligodendrocytes. So as you're looking at some of this literature and you're seeing that SARS-CoV-2 possibly infects multiple different cell types, I just have a little bit of skepticism about whether that's actually true. Viruses tend to have a pretty restricted range in the central nervous system. This is an example of a varicella zoster virus. When it causes CNS infection, in many cases, it can cause more of a CNS vasculitis, and it's probably due to infection in endothelial cells. And you can see these stroke-like lesions in this MRI. And you can see here on this angiogram where you kind of lose some of their normal vasculature. And so these patients can actually present with like a stroke-like presentation. Again, these patients typically have an itis or pleocytosis, can cause these vascular lesions. You can make the diagnosis with PCR. And there's actually some studies that antibody testing might be more sensitive. And again, the virus can infect endothelial cells. So I think this pattern is instructive for what we're seeing with some of the SARS-CoV cases right now. So there's multiple different indirect or immunologic consequences of viruses. And people may argue that acute necrotizing encephalopathy due to influenza may be direct or indirect, but there's other indirect causes, ADEM or acute disseminated encephalomyelitis, Guillain-Barré syndrome, which we saw with Zika virus, and then post-infectious autoimmune encephalitis. So for example, patients with acute HSV-1 can develop antibody-mediated encephalitis after clearing the virus itself. These are just some images showing some pictures of acute necrotizing encephalopathy in a patient with influenza. What's characteristic is you get both gray matter and white matter lesions in some of these patients. Again, typically associated with influenza, a lot of times no pleocytosis, involves both gray and white matter, and usually the PCR is negative for influenza. ADEM, again, more of an immune-mediated event, typically white matter lesions. Again, post-infectious can cause some inflammation in the spinal fluid. These are typically white matter lesions. And again, the CSF is usually negative for causative organisms. So in terms of the original SARS outbreak, there's limited evidence, both currently and previously, for actual CNS infection or encephalitis in people. There's a couple of cases where here you can see nucleocapsid protein from SARS. This is the original SARS outbreak in a patient that passed away due to encephalitis. And so it clearly did happen and was reported on the case report kind of level. And again, this is a second case from the literature showing potential on a CT scan, images consistent with possible encephalitis. And then on pathology, again, antigen positive, what they thought were neurons in the actual brain upon autopsy. So there is limited evidence of case-based human cases of encephalitis. So how could this be happening? So this is a sequencing study from a paper in bioarchives, and they looked at ACE2 receptor gene expression in brain tissue. And you can see here that it's kind of, these are just different in yellow brain regions. And you can see that it's pretty low expression in some of these areas, but in places like the hippocampus, you have kind of a 1 to 2% rate of ACE2 expression. Here's lung on the end, and you can see a much higher expression rate. So the important point here is to remember that it's not just ACE2 that determines tropism. So here's a picture of the virus. Before the virus, so when the virus interacts with ACE2, before it can actually invade and get into a cell, the spike protein actually has to undergo a serine protease cleavage event. And there's different, so these are kind of these type 2 serine proteases. And these are actually very tissue specific serine proteases. For example, this TMPRSS2, which people have probably heard about, is actually highly expressed mainly in the lung. It hasn't been studied much in terms of type 2 serine proteases, but there is one expressed on neurons, and it's this TMPRSS5, but it's not well studied, but they do exist in the brain, and these are important in terms of activating the virus so that it can get into the cell. But there's multiple restriction points for replication. So replication and entry occur in the context of very specific innate immune responses that also restrict these viruses. So for example, there are specific innate immune responses that prevent translation by the host ribosome. There's also host responses that actually decap the RNA and actually can degrade the RNA. And then there's multiple different responses that sense and signal for double-stranded RNA. And so different neurons express these innate immune responses at different levels. And that's an important restriction point for a lot of these viruses, and for SARS-CoV-2 likely as well. So Stan Perlman's group did some studies in mice where he actually took the original SARS virus and he was able to inoculate mice at the olfactory bulb and show that you do get neuronal infection in mouse models, and that's shown here in the brown. And you can see here on the right that you get specific neuronal infection in this humanized ACE2 mouse model that he came up with. So how does this work in humans? So there's, I think, significant concern that a lot of these respiratory viruses could potentially gain access to the central nervous system in a similar route. So we know the virus replicates in the olfactory epithelium, and there's only a couple of synapses between the sensory nerves and the olfactory epithelium and the olfactory bulb, which is in the central nervous system. And we know that viruses can utilize this pathway to get into the brain quite efficiently. So this is just a picture or a diagram of a ferret model looking at influenza. Similar concept. You have multiple neurons here at the mucosa, and only a couple of synapses away from the olfactory bulb. And so what they were able to show, this is just histology here showing how close the epithelium is to the actual nervous tissue. And then the red at the bottom, you can see actually influenza in the epithelium. And then after infection in the olfactory bulb, you can see evidence of virus in the olfactory bulb. Another potential mechanism of spread, which I think is probably maybe less likely in the terms of SARS-CoV, is hematogenous spread. So we know that virus particles can infect endothelial cells. These can result in breakdown of the blood-brain barrier and potentially allow virion particles, free virus particles, to get into the central nervous system. We know leukocytes that can be infected can also migrate into the central nervous system. If those are infected and producing virus particles, then those can carry virus into the central nervous system as well. So that's another potential mechanism of CNS involvement. So in general, in the future, I think we really need prospective studies looking at CSF and imaging from hospitalized patients with potential CNS symptoms versus controls. And we need to be looking at probably nucleic acid and antibody for the actual virus. We need large multi-center kind of autopsy studies to actually look for evidence of virus in CNS tissue. And then if there's any brave ENT surgeons listening, I think prospective kind of oropharyngeal evaluation of COVID-19 patients, especially patients with anosmia and hyposmia or changes in agusmia, would be helpful. So up to about 88% of patients in some cohorts have some of these symptoms. So I think this is important to kind of evaluate in the future. And I think I am done. I'm going to pass it off now to Ken and let him take over.
Thank you very much, Dave. It's a pleasure to come here. I actually have a secondary appointment in the Department of Medicine, so I feel like it's my co-home department. And I come from an era when I actually trained and got board certified in internal medicine, and continued to be engaged with things like the American College of Physicians and the ASCI and the AAP. So it's kind of fun to get to give a grand rounds. Because of limits of time, I'm going to blow through a lot of stuff fairly fast that we can discuss more in the Q&A period. This is changing virtually day by day. So what I tell you today may look different in a few days or a week, but I found it very helpful, and the outline I'm going to use for this talk is to group the neurologic manifestations of SARS-2 and COVID-19 into those that seem to result in indirect effects on the central nervous system, meaning the central nervous system is affected by a much wider systemic process. And that can include things like encephalopathy, that Sarah will talk a little more about in the context of delirium, and stroke, and potentially seizures. And then, as Dave teed up for me beautifully, we also then deal with the more direct effects of CNS invasion in terms of things like encephalitis or meningoencephalitis. And then what's emerging a lot recently in this area is the association with COVID-19 of so-called post-infectious or immune-mediated complications that affect the nervous system. And we'll go through those in more detail later. And then finally, there are a few that I just haven't put into one of those categories because we're still trying to understand the mechanism. Perhaps the first insight into the fact that there was going to be a neurologic story in COVID-19 came from Mao and colleagues in a paper that appeared in JAMA Neurology after it was on a preprint server. And they just basically looked at a bunch of hospitalized patients in Wuhan in COVID-dedicated hospitals. And I don't want you to memorize the numbers or really pay too much attention to them, but just scan the column on the left where it talks about the nervous system symptoms. And you can see, if you just look at CNS symptoms, that in the subset of patients who have so-called severe disease, which was determined on the basis of their pulmonary symptoms, not their neurology, nearly a third of them had CNS involvement. And if you add in some other things like impaired consciousness and cerebrovascular disease as subsets, you can see that those were important as well. And we're going to talk about all of these very briefly. Another series from the University Hospital at Strasbourg, looking at nearly 60 patients, all of whom had ARDS, so were on the severe spectrum of disease, again found a very high frequency of neurologic signs and symptoms. And I think, again, you can see here nearly 2/3 of the patients, for example, had things like agitation, a large number had cortical spinal tract signs, nearly a third or a little over a third had a funny dysexecutive syndrome, by which they meant deficits in things like memory, concentration, and attention. And I want to emphasize that although the neurologic symptom evaluations in these patients were relatively limited, this is most of these were seen in a subset of patients who had relatively little in the way of CSF inflammation, meaning didn't have a pleocytosis, and in only one of the 7 in this series was there even an elevated protein, and none of them had virus amplified from the spinal fluid. So these fall into the broader category of an encephalopathy and overlap with what Sarah will talk about a little bit more. Coming at it from a totally different direction, we're seeing more and more radiographically based papers where the radiologists and neuroradiologists are starting from the imaging and then trying to move a little bit backwards into the patient populations and the radiographic clinical correlations. Here's just an example of one of these studies from Candermerly and colleagues in radiology. About 20% of their hospitalized ICU COVID patients had neurologic symptoms. And they didn't exactly explain how they decided who would get imaging, but about half of those got imaged. And of that group of half, about half of those in turn did not have significant new MRI changes. But what about a dozen of the patients had, and this has been repeated in other studies now, are these funny white matter, diffuse white matter changes as seen here on these FLAIR imaging. And again, I want to stress these were in patients who had an acellular CSF and really very few markers of inflammation in the CNS. One of the most recent studies not only confirmed this and pointed out you could see these kind of abnormalities as shown in the big white arrows here on diffusion weighted imaging, and a little bit less intensely here on the non-diffusion studies, but also pointed out that many of these patients had these funny punctate microhemorrhages. The arrows here are pointing to some in the corpus callosum, both anteriorly and posteriorly. So we're starting to understand that there are radiographic correlates to some of the vague neurology that I just described to you. One of the things that's sort of lacking is the fact that we don't have good controls to understand, are these just the manifestations that you would expect to see in essentially matched patients who were just as ill in the ICU with the same degree of multi-organ failure or hypoxia or other things, or there's some of these that are going to emerge as unique drivers of the encephalopathy and COVID. A very different type of neurologic manifestation that's clearly emerged, and again recurrently as a theme, is the accelerated or increased prevalence of acute cerebrovascular disease in patients with COVID. And in that study I mentioned to you by Mao and colleagues in JAMA Neurology, they saw this in about 6% of their severe hospitalized COVID patients. And in that Strasbourg study, the number was nearly a quarter, but all of those had ARDS. In a series from one of the real bastions of neurologic medicine, the National Hospital at Queen Square, that came out in the Journal of Neurology, Neurosurgery, and Psychiatry, they reported quite early in the epidemic on a consecutive series of about half a dozen, 6 patients with strokes in the setting of COVID. And on the whole, the patients they were talking about, if you look up at the top row there, tended to be older patients, a little bit more of a male predominance, often with a number of associated stroke risk factors. They all had symptomatic and pretty classically symptomatic COVID disease. And one of the interesting features that they reported in that series was that sometimes the strokes could be apparent only delays or delayed after the onset of the COVID symptoms. So if you look at the row where I put the little yellow arrow here, you can see that the day from COVID symptom onset to ischemic stroke onset for 5 out of the 6 patients was between 8 and 24 days. In one patient, it actually preceded the stroke. One of the common features of many of these patients was that they had quite elevated inflammatory markers, think CRP and serum ferritin, and often had very abnormal coagulation parameters, including abnormalities in ferritin and D-dimer. And interestingly, in this series, 5 out of their 6 patients had a detectable lupus anticoagulant, and one of them had antiphospholipid antibodies. So after this paper and others from other centers appeared, we sort of got this image that COVID could be associated with large vessel occlusion, often in multiple territories, could be at onset or at times delayed after the COVID symptom onset, usually occurred in the setting of a highly prothrombotic state, as noted there, and potentially in association with autoantibodies. Something very different then emerged from the experience in New York City, and shown in this paper by Oxley and colleagues from the New England Journal of Medicine. And what they described was not what I just described to you, but now examples of large vessel stroke as a presenting feature of COVID in young adults. So you can see here that young adults in this series was individuals between the ages of about 33 and 49. Again, a male predominance in 4 out of the 5 patients. But what was interesting here here is that several of the patients, as exemplified by numbers 1 and 2 in the columns there, had no classic risk factors for strokes. Again, what they did have was the associated hypercoagulable state and hyperinflammatory state, as indicated by things like ferritin, D-dimer, fibrinogen, and abnormalities in PT and PTT. So one of the big sets then that we've talked about quickly of indirect effects of COVID is both encephalopathy that appeared in basically in severely ill patients, often with associated comorbidities such as diabetes or hypertension, often with multi-organ system failure, and in all these cases pretty much a normal and non-inflammatory CSF and no detection of virus in the nervous system, with a substrate maybe of abnormalities in cerebral perfusion or white matter or microhemorrhages, although whether these are unique or just reflective of all those other factors isn't clear. In addition, we talked a little bit about two types of acute cerebrovascular disease, an older form, adult form in those with comorbidities and severe disease, a younger form in those without risk factors, and usually neuroimaging changes consistent with large vessel stroke, and potentially a substrate of this hypercoagulable state with autoantibodies, and less well documented but speculated the possibility that there's direct viral infection of endothelial cells and endothelial injury contributing to this. So let's shift gears and talk a little bit about the direct effects. The first paper suggesting that this could occur came out in the International Journal of Infectious Disease and described a young 24-year-old man who developed progressive decrease in consciousness, seizures, eventually nuchal rigidity, and a Glasgow Coma Scale score as low as 6. And in contradistinction to the patients that I talked about before, he did have a CSF pleocytosis, and he did have amplifiable virus by RT-PCR in his CSF. And here you can just see a quick example of the hippocampal and mesial temporal signal abnormalities that were present in this case. After that case came out, there was another very similar case reported initially before the CSF studies were done, and then a quick note adding the information on the CSF studies. Again, in this case, a woman in her 40s with nuchal rigidity, photophobia, lethargy, delusions, hallucinations, disorientation, seizures, had a normal CT but never had an MRI done, and now again had an inflammatory CSF with an elevated protein, and again in the second updated report was found to have amplifiable virus in the CSF by RT-PCR. Some studies with less clinical detail have now provided some pathologic substrate to this. So here's just a picture. It's a little hard to appreciate on these EMs, but the authors reported SARS coronavirus 2 consistent particles in neurons and within vesicles, and you can kind of vaguely see some of those there. But more impressively, they also managed to amplify SARS coronavirus 2 by RT-PCR in frozen brain tissue. And in this particular patient, the CSF was negative. There's also been another autopsy series more focusing on the kidney abnormalities in this disease. But what I want you to just see here is one of the columns that they studied doing tissue PCRs was the brain column. And basically, if you were white, they didn't detect anything. And if you were that sort of gray color, that's the lowest copy number level that they sort of detected. And you can see that nearly 40% of their autopsy series, or 8 out of 21, had at least low level of SARS coronavirus RNA detectable in the brain, and that's just shown on the graph as well. In distinction to those patients, there are a number of patients who have all the hallmarks of an encephalitis, meaning an inflammatory CSF and elevated protein, but in whom the CSF RT-PCR has been negative, and there isn't necessarily pathologic material to evaluate. And I think one of the really interesting parts of the story is to try to determine, is that just a sensitivity issue of the CSF PCR, as Dave alluded alluded to, because we certainly know of a number of examples where that is highly specific but not particularly sensitive? Or are there other forms of inflammatory encephalitis in these patients, perhaps mediated by cytokines or other things? Interestingly, although without controls, some of these patients have apparently responded to immunomodulatory therapies like steroids, or there's a series just out in which plasma exchange was used. So to be determined how those fit in. I think it's kind of helpful just in stopping for a second at this point to think in terms of the fact that the disease can produce an encephalopathy without inflammation, and at least two forms of encephalitis, although they may be related, in which there is inflammation, one of which has that virus that can be amplified or found, and the other that doesn't. In just another minute or two, I just want to talk quickly about the post-infectious immune-mediated complications of this disease. What's emerged as one of the most important ones is Guillain-Barré syndrome. This was first reported by Toscano and colleagues, 5 cases who developed a pretty classic syndrome, as seen on this slide, of GBS with areflexia, flaccid paralysis, respiratory failure in many of them, and in some facial weakness, and a typical CSF profile, meaning no cells, and in many of the patients, an elevated protein. All of them were PCR negative. And this was out of about 1,200 patients they had seen with COVID, and during a time frame where the incidence and frequency of this would have far transcended the basal frequency. There have also now been isolated reports of acute disseminated encephalomyelitis, a post-infectious immune-mediated process where myelin is attacked. Most of them have not had pathologic confirmation, but a terrific group at the Mayo Clinic led by Claudia Lucinetti, who's helped us understand many of the patterns of MS, recently did provide good pathologic evidence of a kind of hemorrhagic leukoencephalitis with demyelination, as shown in panel B on the Luxol fast stains, and hemorrhages here, and microhemorrhages throughout the brain as well. So this really does look like it's going to occur. Dave alluded to acute necrotizing encephalitis. This is a funny pattern of brainstem encephalitis and thalamic encephalitis that we've seen before after influenza and other upper respiratory infections. And there have now been several cases of this reported in the context of COVID-19. Again, in general, virus is not detected in the brains of these patients, and it suggests that this is an immune-mediated process. Perhaps the newest kid on the block in terms of a potential immune-mediated syndrome associated with COVID-19 is the so-called pediatric multisystem inflammatory syndrome, or Kawasaki-like disease. At the moment, this doesn't quite fit cleanly into our neurologic pile, except to say that in one of the 10 case reviews of this that just appeared in the Lancet, as we see with Kawasaki's disease, 2 of the 10 patients did have some neurologic symptoms. The last one in just the last minute or so before I turn it over to Sarah that I want to talk about is one Dave alluded to in the introduction of all of these talks. It's been clear that a large percentage of patients with COVID-19 have loss of smell and or taste, or the combination. And in this series here, about 46% of patients had either anosmia, loss of smell, or ageusia, loss of taste. The mechanism of this hasn't been clear, nor is necessarily the fact that it's unique to COVID, although it does seem to be more dramatic and more increased than we see with other upper respiratory infections. And there have now been a few studies, including this MRI one that I just stuck in here, that just appeared in JAMA Neurology, suggesting that this may be neurologically mediated, meaning associated with neurologic damage in the entorhinal and olfactory cortex. The last of the pathologies, more just to mention in case you see it, is in the original series, about 10% or 11% of patients hospitalized in Wuhan had evidence of what was just vaguely referred to as muscle injury with CPKs over 200 and muscle pain. This was more common in those with severe disease. And there have now been several reports of more severe rhabdomyolysis in association with COVID as well. Unfortunately, none of these have given us pathology, so we don't know whether this is an itis or myositis or a myopathy, and whether it's associated with direct viral infection or some other manifestation. So why don't I, having given you that airplane level view, stop sharing my slides and turn it over for the last third to Sarah.
Sarah, I think you may be on mute. Sarah, the mute, yeah, the microphone is on the lower left.
All right.
Okay,
Apologies.
very good. Thank you, Sarah.
So I am going to speak a little bit about the cognitive sequelae of SARS-CoV-2 infection, and particularly what we've learned about this in the setting of other forms of critical illness. And so as we've heard, delirium is a common manifestation of COVID-19. There have been a number of cohorts, as were described previously, that have shown increased numbers of delirium. One coming out of Lombardy, Italy, where there were 26.8% of the COVID-19 patients identified with delirium, and then two that were ICU patient specific, with a large number of patients with acute respiratory distress syndrome out of Strasbourg, France, and then just a couple of days ago out of Indiana University, where they found between 65 and 75% of patients had ICU delirium as measured by the CAM ICU. And as Ken mentioned before, in the Strasbourg group, they found that about a third of these patients had a dysexecutive syndrome at discharge. And in the Indiana cohort, they found that most of these patients, maybe contrary to what we think of in delirium in general, had hypoactive delirium in about 87% of the patients. So this brings up some key questions related to COVID-19 delirium, and particularly COVID delirium in the ICU. And I think some of these were brought up previously, but the first is COVID-19 ICU delirium a different entity than ICU delirium from other critical illness? We've learned a lot about this over the last few years, and we know that this is common in patients who are extremely sick. The second is, what are the long-term cognitive effects of COVID-19 ICU delirium on COVID-19 survivors? And some of this is informed by our experience with ARDS survivors. And then finally, what impact does COVID-19 have on best practices for delirium management in the ICU? So first, just defining delirium. It is defined by the DSM-5 as a disturbance in attention and awareness that develops over a short period of time, fluctuates, and is accompanied by a change in cognition. And simply thought of, it can just be thought of as a manifestation of acute brain dysfunction. We know that it is very common in the ICU, and that up to 50% of ICU patients in the absence of COVID infection have been shown to have ICU delirium. And this is even more common the sicker the patients get, with up to 80% of mechanically ventilated patients demonstrating ICU delirium. It can present in a couple of different clinical forms, both hyperactive and hypoactive, with hyperactive being what most of us think of as delirium with intense agitation, fearfulness, paranoia, but actually hypoactive being more common in critically ill patients, where patients can become calm, withdrawn, unresponsive. And when you look at overall studies of ICU delirium, actually most ICU patients demonstrate a mix of hyperactive and hypoactive. And importantly, it can be missed often in the clinical setting in the ICU if it's not looked for. And in studies that have looked at the absence of routine screening, cases of ICU delirium have been missed in up to 75% of the cases. And as such, there's actually been a guideline recommendation from the Society of Critical Care Medicine to do routine ICU delirium screening daily in critically ill patients. There are a couple different scales that can be used, but the one that's probably most commonly used is the Confusion Assessment Method ICU, or the CAM ICU that I mentioned before, which looks for these hallmarks of delirium that are in the definition. So it looks for a acute or fluctuating course, the presence of inattention, which is really a hallmark of ICU delirium, altered levels of consciousness, and then disorganized thinking. The CAM ICU takes about 50 seconds to administer and is both sensitive and highly specific, with specificities approaching 100%. And as part has become part of our routine bundled care within the intensive care unit at University of Colorado Hospital. Some of you may have heard of the ABCDEF bundle, of which delirium assessment is the D, and I will touch on that bundle a little bit later. So there are some important risk factors that are known for delirium in the ICU. So these are similar to risk factors for delirium outside of the ICU, including advanced age, history of cognitive dysfunction or alcohol and drug abuse, but then also elements specific to the ICU stay. So the presence of metabolic disorders within the ICU stay, greater disease severity, sepsis, hypotension, and then a number of the drugs that we use in the intensive care unit can directly contribute, including benzodiazepines, opioids, anticholinergics, and finally, putting people in bed for prolonged periods of time with immobilization can also exacerbate their delirium. But as you've heard in the first two talks, there are probably also some COVID-specific risk factors that are combining with these known ICU delirium risk factors to increase risk in COVID-positive patients. And that includes the virus-related factors that we've heard about, but also increasing social isolation, both before the hospital stay and during the hospital stay. And then there's some concern that active agitation in the setting of hyperactive delirium may actually spread virus. So there's been a push to use more sedating drugs at times to try to reduce the risk of agitation. We know, again, prior to COVID, that ICU delirium is associated with worse ICU outcomes. It is an independent risk factor for 6-month mortality and associated with longer lengths of stay and less ventilator-free days. In addition to the short-term outcomes, we know that ICU delirium is the biggest risk factor for long-term cognitive impairment in ICU survivors. So this is work done out of Vanderbilt with a prospective cohort of medical ICU patients, many of whom had acute respiratory distress syndrome, who were followed with cognitive testing at 3 months, 6 months, and a year after their critical illness with a standardized testing scheme. And they found within their cohort that at 3 months, 40% of the cohort had cognitive scores at the level of traumatic brain injury, and that this persisted in about a third at 6 months. And in addition to that, they found that about a fourth of patients had cognitive impairment at the level of dementia. And again, this persisted out to 6 months after the ICU stay. And when they looked at risk factors for lower cognitive scores at a year, they saw that the number of days of delirium was significantly associated with lower cognitive scores at 1 year. Further, they saw when they looked in this cohort that the use of benzodiazepines was associated with an increased risk of long-term cognitive impairment, and that the higher the benzodiazepine doses were, the worse 3-month executive function was for ICU survivors. And this is of particular importance in the setting of COVID currently, because there have been some drug shortages related to sedatives in the ICU that have resulted in some increased use of benzodiazepines and other sedatives that may contribute to longer-term cognitive dysfunction. In addition, we know that non-factual memories, which are common in the setting of ICU delirium, can not only contribute to cognitive dysfunction, but also to post-traumatic stress in ICU survivors. This is a study that looked at the presence of non-factual memories, and they found that at day 28 after critical illness, 70% of the survivors still reported delusional memories. And the presence of delusional memories at 2 weeks after the ICU stay was significantly associated with the presence of PTSD at 2 months after the ICU stay. And this picture here is actually a picture drawn by an ICU survivor of what her experience and her memory of the ICU was, where you can see her floating as this figure above her bed with all of these people coming in as ghost-like figures around her, which is not an uncommon description that we hear from ICU survivors. And so looking at our local survivor experience, we've actually established an ICU recovery clinic here at the University of Colorado Hospital, where we are doing telehealth-based clinic visits with a multidisciplinary team for ICU COVID survivors. We do standardized screening for cognitive impairment using the Montreal Cognitive Assessment. And then we also do mental health screening for depression, anxiety, and PTSD. We've seen 13 ICU survivors to date, and amongst those, we've seen 77% with a history of ICU delirium, of whom 40% have ongoing cognitive dysfunction. So pretty similar to what the French and Indiana cohorts have seen, and not uncommon from what we've seen in prior historical cohorts of ARDS, critically ill survivors. So what can we do about trying to reduce this ICU delirium? Well, the key is really prevention, trying to keep patients from becoming delirious to begin with. And this gets back to the ABCDEF bundle that I mentioned before, which has really become a standard of care in the intensive care unit. And the goals of the ABCDEF bundle are to minimize sedatives, to liberate patients quickly from the ventilator, to reduce their chance of delirium, to assess and treat delirium early, to mobilize patients early in the course of their ICU stay, which has also been shown to reduce their days with delirium, and then to engage and empower families, which helps with reorientation and also helps to decrease delirium within the ICU. So we know that bundled care, like the ABCDEF bundle, improves outcomes. It's been shown to result in increased liberation from the ventilator, earlier ICU and hospital discharge, an increased return to normal brain function, increased independence at hospital discharge, and also increased survival. But COVID-19 has made this a little more challenging. And some of the things that we particularly do for bundled care have become more complicated in the setting of COVID. So we've had to restrict visitation, which has resulted in a lack of family engagement with patients. We've had to limit non-pharmacologic treatments such as early mobilization outside of the patient's room to reduce the infection risk. Patients have increased psychosocial stress related to the pandemic itself, along with their critical illness. We've had some disruptions to religious and spiritual services, which often serve as a bridge and reorienting state for the patients. We've had an increase in healthcare professional workload, which has made doing some of the bundle elements a little bit harder over time. And then, as we've heard, the virus itself has this evolving neurocognitive dysfunction that can result all of these entities together in an increased risk of delirium for ICU patients with COVID-19. So as I've mentioned, delirium is common in ICU patients. It's multifactorial in nature and associated with increased mortality and increased long-term cognitive dysfunction. There are certainly COVID-specific risk factors and healthcare limitations that may serve to increase the delirium risk in our COVID-positive patients. But we still would advocate for aggressive early delirium screening and intervention to improve outcomes, although this may be more challenging in the setting of COVID. And with that, I'll take any questions.
Sarah, that was great. Dave and Ken, kudos to you as well. I want to remind everyone before we get started with the Q&A period that the discussion If you're interested in getting CME credit for this talk, the QR code is in the upper right corner of your screen, and you can use that to get your CME credit for this, for participating in this talk. Let me start out with the first question that I think is an important one. How do we separate out the direct CNS neurologic effects from the sedative analgesics in intubated patients, and even more complicated and specific to coronavirus infection? What about the novel agents like remdesivir and hydroxychloroquine, as well as anti-IL-6? How do you begin to separate those out from each other in terms of the clinical evaluation and also a more definitive causal relationship?
Hey, this is Ken. Maybe I'll jump in and start. I think one of the key hallmarks separating various types of encephalopathies, including those that might be, induced by metabolic dysfunction or by drugs, is the absence of inflammation in the spinal fluid. So I think one of the tip-offs that you may have something else going on, a true encephalitis, as Dave referred to it, is by looking at the CSF and seeing, is there a pleocytosis? Is there an elevated protein? I think the second piece is obviously looking for evidence of direct viral infection by RT-PCR in CSF, although it remains to be seen whether a negative reduces the probability of that. A positive is certainly helpful. And then finally, I guess the MRI appearances can be helpful as well.
Any other thoughts? What about the clinical evaluation? And Sarah, in particular, when you're at the bedside in the ICU, how are you assessing the potential effects of medications and interventions on the cognitive effects of?
Yeah, so I think that we know that delirium is so common in the ICU that's why things have really shifted towards the ABCDEF bundle, to try to assume that patients are likely at risk of developing delirium and to try to minimize as much as we can early on. So trying to get the sedatives off as quickly as possible, trying to get them extubated as soon as possible, trying to get them up and moving, which will improve delirium, and also engaging families as much as possible. And so I think we kind of try to de-escalate as much as we can up front to try to better determine what the effects of these different components are.
Mm-hmm. Okay, good. So we're a little confused about the immune effects of the virus versus the direct toxic effects of the virus. So tell us how immune markers like cytokines or inflammatory responses can help us sort those out and help us think about novel therapeutic approaches to infection with the virus.
So I'll jump in on this one, I guess. So, I think what Ken kind of outlined a minute ago is kind of the key. If you have direct neuroinvasion causing altered mental status or a presentation, then those patients, should have some type of inflammatory CSF, maybe an elevated protein, plus or minus some imaging abnormalities. So I think direct neuronal invasion in terms of viral encephalitis in general is associated with a CSF pleocytosis. And we kind of use that as a baseline. And then I think separate from that, if you do or have some imaging abnormalities along with some focal neurologic findings, a lot of times those imaging abnormalities in the presence of a normal CSF can actually be indicative of a specific pattern or a specific type of immune-mediated response. In terms of, I think, some of these inflammatory markers, CRP, D-dimer, I think, so many of our patients have elevated inflammatory markers that it's going to be very difficult to use those as a predictor of CNS complications. And so I think that's going to be difficult to make that link. And I think you're going to be stuck having to look at neuroimaging and spinal fluid tests.
Hey, this is Ken. The only thing I might add is it's sort of relatively in its nascency, so we don't have great standards, but more and more of the papers are looking at things like CSF cytokine profiling, and it'll be interesting to see whether or not there's a unique signature for this as opposed to, say, other viruses, or this as opposed to some of the other conditions that you alluded to. And of course, if there is evidence that, say, pro-inflammatory cytokines, including IL-6, play a role, it suddenly makes some of the studies that are ongoing here and elsewhere, looking at specific IL-6 inhibitors or other inhibitors of pro-inflammatory cytokines, interesting as therapeutics.
So given the number of organisms in the nasopharynx, why don't we see more transmission of virus into the brain through the olfactory bulb?
I'll take that one. I'll take a stab at it. So it's actually a really interesting question. We actually have 3 grants right now that we've submitted over the spring to study olfactory pathways and associations with neuroinvasive infections. And it's a real interesting question. There is some data that the olfactory bulb and the olfactory pathway has a very unique innate immune signature, different from the rest of the brain. And that area, because of its exposure to the environment, exposure to pathogens in the upper respiratory tract, that potentially has a unique innate immune signature that makes it more resistant to infection, and that's evolved in order so that we can maintain taste and smell and things like that. So I think it's a great question. Why doesn't influenza, which is common, or other respiratory viruses that could potentially invade or cause infections in these neurons, why don't they do it more commonly? And it's definitely an area of active study. And I don't think we have a great answer. I don't know if Ken or Sarah have other insights.
No, except to say that, we obviously do see isolated examples with things like cases of rabies and people spelunking in bat-infested caves that have been reported that are presumed to be entry via that route. There's a lot of interest in that as a flavivirus pathway, and even with herpes simplex. So it may occur more frequently than we give it credit for. And as Dave alluded to, ultimately the question would be, do you have the receptor for the virus on the susceptible cell? And what's the host defense mechanism, given that's probably the only place in the entire body that naked nerve fibers are exposed to the outside environment to defend against this happening.
Oh, Ken, you brought this up, so I'm going to have to follow up on this question of bats. What's special about bats? Why the heck are bats all of the vector of, the harbinger of all of these terrible viruses?
I'm going to turf to Dave. Is that allowed? Can I get a lifeline here?
Yeah, so there's been a lot of discussion about this before even SARS-CoV-2. There's Hendra, there's Nipah, there's Ebola, Marburg. There's all these different viruses that bats seem to tolerate and seem to spread these viruses amongst them. And it's probably due to multiple different reasons. Bats are an ancient species. They've been around over 50 to 70 million years, so a lot longer than us, and they've definitely co-evolved with these RNA viruses. Bats have a unique structure in which they're very that they live in large groups, and so they probably transmit these viruses in large groups quite easily. And then these viruses have evolved to be able to maintain some sort of persistence in these bats without causing disease necessarily in the bats. And so there's been a coevolution between a lot of these viruses and the bat's innate immune system, where the bats can control the virus with a very unique, actually, innate immune system. But the virus is able to persist, and that's been a benefit to the virus. But then obviously, as people chop down forests and move into areas where these bats are native, we get exposed to these viruses that are existing in a natural reservoir, And then these viruses are able to adapt in some situations to spreading amongst people, unfortunately.
The only thing I might add is usually there's an intermediate host. So, whether that's the pangolin, the civet, camels as for the coronaviruses, pigs for Nipah and Hendra, often it's back to something else that we're then exposed to. So there's also an intermediary link to consider.
Great. What about, how do we get our patients that survive COVID infection connected to the ICU Survivors Clinic? And tell us a little bit more, Sarah, about the ICU Survivors Clinic. What are you doing for these folks? And is there a multidisciplinary approach to this problem?
Yes, so you can get them into the clinic just by putting in a pulmonary consult to the general pulmonary clinic and putting for post-ICU COVID care. We've put together the clinic with a multidisciplinary group of providers from rehabilitative services, so physical therapy, occupational therapy, and speech therapy, along with our colleagues in psychiatry and rehab psychology to help with kind of the mental health component of long-term recovery. We know that the deficits that come with post-ICU care extend beyond the cognitive dysfunction and actually encompass a whole syndrome by themselves called post-intensive care syndrome, which is manifest by the cognitive dysfunction, physical dysfunction, usually manifest as weakness, and then also the emotional distress that comes with the course of recovery. And so we have a multidisciplinary team in place to try to approach all of those different deficits to improve outcomes in the year after critical illness.
Mm-hmm. Okay, great. And is there proof that does improve outcome? Has that been studied? I mean, it makes sense, but the question is it effective?
Yeah, so there's more and more studies coming out because the number of post-ICU clinics has been increasing over time. So it was just a few small places that had these post-ICU clinics in place. We do know that survivors of critical illness are at increased risk for mortality in the year after, along with increased risk for rehospitalization and increased healthcare needs. And they've shown that there's a reduction in the need for healthcare utilization, but no change in terms of long-term mortality or longer-term deficits. Mm-hmm. Although the hope is that as more of these post-ICU clinics come on board, we can do larger studies across centers to actually show improvement in outcomes.
Really important, innovative work. So what's the pathophysiology behind agitation causing increased spread of COVID?
Yeah, so it wasn't clearly explained. It's a theorized risk that just by the patient being more agitated, that they breathe more and they cause more aerosolization, but there wasn't a great explanation for how or why.
Not a great explanation, okay. Let's get back to how the virus gets into the CNS. We talked about the olfactory route, but what about the blood-brain barrier? And to what extent is the virus causing reactive oxygen species to break down the blood-brain barrier like what happens in HIV?
I'll take a stab at that one. I think the short answer is we don't know how the virus, if it gets in routinely into the CNS, and if it does, how it does. But I think there's a couple of different potential routes. One, we've already talked about the olfactory pathways. Two, a common route for these viruses to get into the central nervous system is through hematogenous spread. And there's typically a couple of different ways they can do that. One, the virus can actually infect the epithelial cells themselves. And then during that process, as you mentioned, they can produce injury to the epithelial cells, produce reactive oxygen species and things like that. That's also associated with the inflammatory response itself. That can actually decrease the blood-brain barrier and allow potentially more virus to get in. And that's a relatively feasible way that this virus could be doing this. The other potential mechanism is we know white blood cells move in and out the brain and are trafficking in and out. And so there is this Trojan horse method that some people claim could play a role. I think in terms of this virus, I think that's much less likely, where you have ongoing infection of a innate immune cell like a monocyte or a macrophage, and it's trafficking into the central nervous system, carrying virus in as well. But again, I think that's a potential mechanism, but I put that much lower on the list. I don't know what maybe Ken or Sarah think as well.
The only things I might add is if we think about other neurotropic viruses and viremias, some of the lessons we've learned in other settings is probably there's the higher the magnitude of the viremia, the greater the chance of CNS infection, that anything that you do that impairs or breaks down the blood-brain barrier mechanically or otherwise facilitates spread from the bloodstream into the nervous system. So things like diabetes or hypertension or other things like that that might create vascular abnormalities could play a role there. We know that certain interferons, there's been a lot of interest in interferon lambda in West Nile virus and the effects it has on the blood-brain barrier. And I think someone asked about reactive oxygen species. To be honest, I don't know much about that in the setting of SARS-CoV-2, but I know there was some old work with some other, including some of the porcine neurotropic coronaviruses that did suggest they could activate reactive oxygen species, and that could, at least in cell culture models or other things, contribute to virus-mediated cell death. So just don't know that much specifically about the studies or what have been done on SARS-CoV-2 in that particular area.
So to the non-neurologist, the blood-brain barrier is a concept. Tell us the structural element, remind us what the structural elements of the blood-brain barrier are.
So, basically you start with the endothelial cells of the microvasculature. And for most of parts of the brain, those are joined together by tight junctions. Although, as Dave alluded to, there are a few odd areas of the brain where you still have fenestrated capillary endothelia, including around the choroid plexus, for example, and the area postrema and some others. And then on the other side of those endothelial cells, they're covered with what are called the foot processes of astrocytes and some other cells. So there's another component there of sort of almost like a lining around the capillaries with astrocytes and other cells contributing. And it's not an absolute barrier. It's just in general, things in the bloodstream obviously don't easily typically get into the CNS. And as Dave alluded to, the ways of doing that are natural gaps in the barrier, meaning anatomic ones, induced gaps, potentially cells that migrate across that, which we know occurs regularly. And also in some diseases where either viruses directly infect endothelial cells, and that has clearly been shown for SARS-CoV-2, including some recent studies that include brain microvascular endothelial cells and clearly show viral particles in those cells. And then finally, as I said, astrocyte processes that or diseases that could hurt astrocyte processes could be another way of disrupting the barrier.
So large and small vessel stroke is clearly a risk in SARS-CoV-2 infection. Tell us about the risk-benefit thinking as it relates to prophylactic and also therapeutic anticoagulation.
So I think it's a really dangerous area to speculate on because there really is no knowledge. And I think the approach, understandably, that most people have been taking for this, and I would extend it actually to things like GBS and the immune-mediated diseases, is of course we start trying to treat these things the same way we would treat similar processes in other settings. And so people have used everything from antiplatelet agents to anticoagulants anticoagulants to clot extraction, just like we would under normal circumstances. But whether or not one of those is better than another, more effective than another, whether there are other things we should be doing, I think there's almost no data on. And similarly, as I say, if we think about, say, the Guillain-Barré models, or the things like ADEM or others, we would be thinking about approaches like IVIG, plasma exchange, and things like that. And that's exactly what has been reported. But we just don't have any insight as to, are the therapies going to work as well in those settings as they do in other settings. So I think this is still an area that we just don't have much data about to help us guide or alter, the kind of usual approaches.
And should we be using inflammatory mediators like CRP, D-dimer, ferritin to guide that decision making?
Well, I actually think one of the things that struck me is that in both the adult setting with stroke and in the pediatric setting, that the vast majority of the patients that this is occurring to have very abnormal, both inflammatory markers and things like D-dimer, fibrinogen, and others. So I think at the moment that seems to be the smoking gun, whereas the things like the endothelialitis seem to be more of a theoretical possibility that this might occur or could occur. So yes, I would have thought that that is something we should and can go after.
Mm-hmm. Okay. What about the myopathy that's associated with this? Is this due to the chronic illness that you see, Sarah, that you take care of, or is this a direct neuromuscular infection caused by the virus? We know the virus infects heart muscle. Why wouldn't it infect skeletal muscle also?
Yeah, and I think it's probably a combination of both. I mean, we certainly know that critical illness neuromyopathy is common in ICU patients, just like delirium is common. And so some of this is probably related to their underlying critical illness and the fact that they're so sick, but there probably is some virus-specific contribution.
Okay. And who's studying that here, the myopathy associated with coronavirus infection? Is there anyone studying it in neurology?
No, I don't think so. We have a pretty active neuromuscular group and do a lot of muscle biopsies and things like that. But I don't know that anybody, this is also new, that I'm not sure that there's anybody I can quickly think of as specifically studying that. As I say, it's an interesting field of research because, influenza and others are known for producing myalgia, and it's been unclear in some of these other viral infections, how much of this is really, is there inflammation? Is there evidence of the virus there? Or is it all, as Sarah was saying, an indirect, mechanism? So it would be a fruitful area for research.
I will say my K23 looks at the impact of pre-hospital alcohol use on neuromuscular dysfunction and myopathy and critical illness. And we are actually going to look at a COVID subset of that to try to see if this is more COVID or ICU associated neuromyopathy.
That's great. That's good. Let me go back to this issue because I know that it's confusing to a lot of people, and probably because we just don't have enough information yet. Are these individuals people that are at risk for stroke, and coronavirus is just causing the manifestation of that risk that they had, an inflammatory response and part of the or is this actually caused by coronavirus infection? Two separate issues. Is it an individual who has zero risk factors for stroke and comes in and has a stroke because they have a COVID-19 infection, or are these individuals people that you would suspect as being at risk?
I think the correct answer is yes and yes, meaning that it's clear that if you look at the older individuals, not surprisingly, they often have multiple associated classic stroke risk factors, and then you're throwing another prothrombotic or procoagulable thing into the mix. But I think the interesting thing about the quote stroke in younger adults is that might be a little bit of a cleaner population, and it is clear that there's a subgroup within that subgroup that, at least as we would normally interpret it, have a few, if any, risk factors that we would conventionally think of for large vessel stroke, and yet who do develop stroke in the setting of COVID. As I say, usually with these abnormal coagulation markers that we just talked about, including some autoantibodies. So I think if you're at risk for stroke and this happens, this is yet another thing that may tip you over the edge. But I also think it's clearly emerging that there's a subset of people where they don't have those obvious risk factors, and COVID seems to be the thing that pushes them over the edge in terms of stroke.
I was afraid you might give us that answer. We really do need to learn more about this. Because by definition, it could be preventable. And the question is how to identify those individuals that go on to have stroke. Any other thoughts on that from Sarah or David? No? Let me ask a question that is perplexing to me. What's unique about these different areas of the brain that would attract West Nile virus to one area of the brain versus varicella virus to another area? What are the unique characteristics of that brain tissue?
I'll take a initial stab at that. I mean, so for West Nile, for example, there's been some actually really good studies showing that there's a couple of different factors that play a role in this kind of region-specific tropism. For example, Mike Diamond's group with West Nile virus showed that individual neurons have specific interferon-stimulated gene responses that restrict West Nile virus to specific areas of the brain, such as the cerebellum and the subcortical area, whereas the cortical neurons have a different ISG response that prevents the virus from growing as well or replicating as well in the cortex, and that probably plays a role. And independent of that, it's a little bit dependent on the virus as well. A pyramidal neuron in the cortex is very different than a dopaminergic neuron in the midbrain, and they have very different metabolism, different features in terms of lipids and how they react and how they tolerate an immune response or an interferon response. And so it's probably a number of different things between receptors and but also kind of innate immune restriction factors that are present in these different areas of the brain, at least based on what we know. And I'll stop there.
Yeah, this is Ken. I agree with Dave. I might just argue that, you also have the issue of what is the viral cell attachment receptor and how is it distributed? Are there post-binding factors, transcription factors or other things that might also play a role in restricting replication? And we know with some other neurotropic viruses like JC virus or others, where it's not the receptor binding thing that it causes the specificity, but post-receptor attachment things. And then I think the thing that Dave alluded to, that, we tend to think, well, wait a minute, the whole brain probably has a pretty similar, innate immune response and other things like that. We're learning is pretty much probably wrong, and that there may be much more regional specificity than we, than we thought was, the case.
Right. Yep. Well, tell us a little bit more about the immune response to the virus in the CSF. We heard that PCR can be positive for coronavirus in the CSF. What about antibody? And And if so, what about PCR of specific immune cells in the CSF?
So the field, I think Dave can jump in too, but and maybe Sarah, is still kind of in its infancy as it applies specifically to SARS coronavirus 2. I guess what I would have said is that for other neurotropic viral infections, and I think Dave maybe alluded to two of them in his talk, West Nile and the acute flaccid myelitis associated with enterovirus D68, that we know in both of those two settings that actually looking for intrathecal antibody synthesis may be a more sensitive method of detecting viral infection in the nervous system than PCR. So for example, in acute flaccid myelitis, 50 or 60% of the kids will have a positive nasopharyngeal RT-PCR for enterovirus D68, but only about 2 or 3% have detectable positive PCRs in the spinal fluid. And the thing that has a much higher association is to look for detection of specific intrathecal antibody synthesis, as several groups have now shown. So the procedures are complementary, and I'm not sure we understand why is it that in some viruses the sensitivity is so great, think herpes simplex encephalitis, where in others it's so terrible, think enterovirus D68 in AFM. And so I think that remains to be determined.
What do you think about the long-term complications? I mean, this is obviously theoretical, but the question is, are these individuals, do you think, at higher risk for Parkinson's disease in the future? Will there be persistent memory problems in these individuals, not counting those with stroke? What do we know about other coronaviral infections, MERS or CoV-1, that could give us some insight into the chronic neurologic sequelae of infection?
I'll jump in first. So in terms of some chronic effects, we do know that, and there's an emerging literature that some of the pathways associated with neurodegeneration, especially in Parkinson's disease, potentially in Alzheimer's as well, do overlap with some of these innate immune cellular responses in neurons. And so there's kind of an emerging literature that is suggesting that these types of CNS insults or infections can potentially increase your risk of long-term cognitive decline or long-term neurodegenerative disease. That's yet to be established, but it is definitely a concern. There was for example, a cohort of patients studied after the 1918 flu. That study suggested that patients that were exposed to influenza in 1918 did potentially have a higher risk of developing Parkinson's disease long term. And so it's a question that I actually get a lot because it's something that we do research on. And I don't think we know the answer, but I think it is of concern that these kind of neuroinflammatory events could potentially put people at risk for some of these long-term neurocognitive outcomes.
So maybe I'll be a little more upbeat and say, so far when we've looked at the patterns of encephalitis that we've seen, they don't seem to be targeting, particularly the basal ganglia, the thalamus, or the usual Parkinsonian pathways. The exception maybe being those super rare cases of acute necrotizing encephalitis. So I think that's potentially good news, as is the fact that the post-infectious immune impact on white matter is something where we have the capacity to remyelinate and do other things. The thing that actually scared the crap out of me the most was when Sarah kind of in her talk alluded to the fact that agitation and delirium in the ICU is a marker for potential bad or worse cognitive outcomes, but that would be true, across multiple etiologies. So, that one is a little bit frightening because obviously these patients, especially the really sick ones, are enriched in just those things that have been bad prognostic factors. So I don't know if Sarah wants to say more about that.
Yeah, and I think that's the concern I have is the combination of the two, because we know that ICU delirium is bad by itself in the absence of COVID, that having, if there is a COVID specific element to this, it may just be synergistic and make the cognitive impairment worse. And so I think that we'll know more in the next year, but what we know from other critical illness and ICU delirium as a whole is that it is a big predictor of long-term cognitive dysfunction.
And Dave, the only other thing I might add is, remember the number of cases of both SARS, type 1 and MERS were so small that the opportunity, and both of those were also, of course, relatively recent events, 2002, 2012, that kind of thing. So we don't either have the numerology or the duration to know whether or not those would give us a clue, like Dave was alluding to when he gave his introduction, as to what we might see with COVID-19.
And to paint a little bit more of a sunny picture, we do know that about maybe 15 to 20% of patients that present with acute West Nile encephalitis can actually present with a Parkinsonian-like syndrome. And the vast majority of those patients actually do improve over time from that acute insult. And so, but like Ken said, it's hard to know. We don't have the numbers really to know the long-term effects of these infections.
Okay. Well, I think that's a good point to end on. Thank you so much for informing us, letting us know what's known about this area and what we still need to learn about this area. This is obviously an evolving area of clinical science and basic research, and there will be exciting developments in the future, and there's a body of literature for us to be able to take care of patients who have this infection and are affected in terms of neurologic problems. Great discussion. Thanks very much. Really appreciate it. See you all next week.
Bye-bye, and
Thank you.
thanks for inviting us.
Thank you.
Thank you.